This introduction to basic intracranial pressure will help us as we work through all of our intracranial issues that we're going to look at, because most of them result in increased intracranial pressure. So this gives us just sort of a foundation to work off of. So let's start with a basic review of anatomy. Your brain stem is where the brain and the spinal cord attach, and that's where most of your vital functions, heart rate, respiratory rate, etc., are controlled. So this is a very important part of your brain. The cerebellum is this extra sort of under part of the brain, and this controls balance and coordination and helps you have smooth, seamless movements. And then the main thinking part of your brain is the cerebellum. That's where all your white matter and your gray matter are. But in here, in the middle of the brain, we've got some glands, the pituitary gland, we've got the thalamus and the hypothalamus, and then we have these ventricles. And in the ventricles, your brain creates cerebrospinal fluid. And that is supposed to, in normal function anyway, come out the bottom of the ventricles, and then it circulates around the surface of the brain. So again, coming kind of out the bottom and circulates all around. That cerebrospinal fluid even goes all the way down the entire spinal cord. We also then have the lining of the brain called the meninges. They're the sort of fibrous coverings between the brain and the skull, and then of course the skull itself. Remember that in older children and adults, that skull is fully fused, while in young infants, the sutures and the fontanelles are still open, so the skull is capable of expanding. The other important thing to remember is that all of this tissue is very vascular. There are a lot of blood vessels because the brain requires a lot of nutrients and oxygen to stay functioning, so there's a rich blood supply there. This picture just gives us a wider view. So again, the brain, the skull, everything contained in there, and then here's where your spinal cord comes down the back, and you'll notice the spine itself, the vertebrae, continue all the way down to your tailbone, but the spinal cord stops here right around T4-ish, and that will become important as we try in certain cases to collect samples of cerebrospinal fluid. We remember that there's a gap here where it's okay to introduce a needle into that spinal space. Of course, remember that in real life, you can't see the spine like you can in this picture. The bones, the vertebrae, do protect the entire spinal cord, and so it's entirely surrounded by bone, just like your brain is entirely surrounded by your skull. Our focus in this video is going to be what happens if there is an increase in intracranial pressure. So we're looking at the pressure in your cranium or your skull. So there's of course all the structures that are in there. There's cerebrospinal fluid, and there's blood. So any modification in any one of these three things can cause an increase in that pressure. With structures, for example, this could be swelling, this could be tumors, a structural defect. Cerebrospinal fluid, if there's too much cerebrospinal fluid produced, or if it's not reabsorbed correctly, or if it's not able to escape from the ventricles properly, then that will increase your pressure. And then blood, whether it's bleeding in the cranial space or excessively high blood pressures throughout the body, that can all increase the intracranial pressure. Normal pressure is 5 to 15 millimeters of mercury, at least for adults. The values for children, depending on age, are a little fuzzier. We don't have quite the same strict guidelines, but generally speaking, if you can remember that 5 to 15, you're on the right track. The problem with increased intracranial pressure is that the higher your pressure goes, the less perfusion or blood flow you have to the brain tissues. So if that situation persists for too long, we end up with tissue death or permanent brain damage. Of course, tissue death just causes more inflammation, which causes more intracranial pressure, which causes a decrease in perfusion, and it becomes a vicious cycle. So let's look at how we would assess increased intracranial pressure, remembering, of course, that adults and young children might look different from each other because of the difference in that structure of the skull. So the first thing we want to know if somebody presents with increased intracranial pressure is, what's the history? What story surrounds this? Have you been ill? Is there an injury? What's happened? And then, of course, a good set of complete vital signs, and we'll look at why those vital signs are so important in a minute. We'll also look at the Glasgow Coma Scale, usually abbreviated GCS. And then don't forget that we can also do other neuro checks, like checking someone's pupils, checking their motor function, or checking their cranial nerves. If I'm concerned that there's damage to the spinal cord as well, we would add those deep tendon reflexes like the patellar reflex. So now let's look in more detail at what signs and symptoms we would see in infants who still have an expandable skull. Up here at the top, you can see that this child looks quite surprised, but actually this is what we call sunset eyes, where it looks like the cornea is actually sun setting on a horizon. What's going on here is that there's so much pressure from inside the skull that it's actually pushing down on the eyes, driving those eyes down. The next picture is this bulging fontanelle right here. So you can see that instead of a nice flat curve across the top of the head, you can obviously see that soft spot, that fontanelle bulging out. That's a clear indicator of increased intracranial pressure. Sometimes, though, the fontanelles may be small, may be harder to see, but we still see an increased head circumference, like in this picture here. You'll also notice that the veins, the scalp veins, are very visible on this patient. That's another common sign of increased intracranial pressure. Systemically speaking, we'll likely see decrease in PO intake, irritability, and a high-pitched cry. It is an unusual sounding cry that is pretty hard to miss, even if it's hard to picture before you actually hear it. For older children and adults who have a fused cranium, we don't see any of those expanding skull features. But these children and adults are now old enough to report more symptoms to us. So we'll start with the picture and then we'll list some of those other symptoms. What you see here is a picture of some different pupil assessments. So in a normal pupil assessment, the pupils really should be fairly equal and they should respond quickly to any kind of light stimulus. If someone has fixed dilated eyes, this is a common sign of increased intracranial pressure. It can also be a sign of certain toxicities, like a stimulant overdose. If the pupils are unequal, it means there's some kind of increased intracranial pressure just on one side. So this patient's right eye is dilated, so I know that the left brain is affected, because remember, those cranial nerves cross as they pass through the brain. Of course, just a note, if you have pinpoint pupils, that's a sign of opioid overdose. So look out for that too. The pupillary response is not the most common sign or symptom we see, however. The most common is headache, and usually reported as a severe throbbing headache, and that can be followed by vomiting. But this is vomiting that does not have accompanying nausea a lot of times. someone will just sort of wake up in the morning and vomit without actually feeling sick. As it progresses, though, we do see an appetite decrease again, much like the infants. We can also start to see visual changes where the patient will actually report double vision or blurring vision, or seeing little flashes of light or floaters kind of crossing their vision. And as we progress further and further, we might see seizures, ataxia, which is that unsteady, uncoordinated gait, or decreased level of consciousness. As that increased intracranial pressure continues to worsen, we will start to see some concerning emergent signs that would need to be reported right away to the provider. So the first is if the patient is unresponsive. And we'll look at the Glasgow Coma Scale in 1 minute just to help us quantify that level of response. Of course, those fixed dilated pupils that I mentioned, that's a concerning finding. And then finally, we have a group of 3 symptoms known as Cushing's triad. So the first is an increase in the systolic blood pressure, but there's a widening pulse pressure. In other words, the diastolic blood pressure is either staying approximately normal or even decreasing as we get worse and worse. Number 2, we see a slowing of the heart rate. And number 3, a slowing of the respiratory rate, and those respirations become irregular. So if you ever see these 3 symptoms in your patient with a concern for intracranial pressure increases, that is very concerning. In case you have not encountered this before, this is the Glasgow Coma Scale, and we can use it to quantify someone's level of consciousness. So you can see that there are 3 components to this quick little exam. We start with eye opening, and we ask, does the patient open their eyes spontaneously, only when I talk to them, only to a painful stimulus, or do they never open their eyes? And we score accordingly. Then for verbal, are they oriented all the way down to there are no verbal noises at all? Notice that for infants who are not supposed to be verbal yet, there is a modified scale. And then for motor, we see if they'll follow simple commands, or do they react to a painful stimulus? Do they sort of point to it? That's the localizing, withdrawing away from it. And then we have abnormal flexion and abnormal extension, which I will show you pictures of in 1 minute. And then you add everything up, so your best score possible is 15, your worst score possible is 3. Now, if your patient is intubated, then we use this T, so you would get 10T as your best score and 2T as your worst score, because if they're intubated, we cannot assess the verbal component. Okay, these are the 2 postures that are listed on the Glasgow Coma Scale. So the abnormal flexion is this decorticate posturing down here. This scores a 3 on the Glasgow Coma Scale. And the abnormal extension is the decerebrate posturing, and that scores a 2 on the Glasgow Coma Scale. You can remember decorticate because core is the middle of something and the arms are drawn up towards the middle of the body. Both of these indicate a pretty significant brain injury. The decerebrate posturing is particularly ominous. Once we've diagnosed someone as having increased intracranial pressure, there are a few things that we can do sort of regardless of the cause, but of course, remember, for any of this medical management, we would need a provider's order. So a common medication we see is mannitol. This is a sugar that we inject intravenously, and through osmosis, it draws extra fluid out of the brain tissues and into the bloodstream, allowing the kidneys to filter that extra fluid out of the body. So this is particularly useful if there's any kind of swelling in the brain tissues. Sometimes we'll also see steroids, although the research is still inconclusive on this topic. But again, trying to reduce inflammation, reduce that swelling within the cranium, that's why we might see steroids. A lot of times if someone is in a state of significant increased intracranial pressure, they will also need intubation and respiratory support. So there's a lot of sedation or even paralytic medications that go along with that. So those would require some pretty intensive monitoring to make sure that respiratory needs are met and we're not over-sedating anyone. We also saw that seizures were a symptom, so you may certainly see anti-seizure medications. But ultimately, what we need to do is treat the cause. If we can treat the cause, then we can hopefully resolve the dangerous increase in intracranial pressure, and we can remove these symptom management measures. From a nursing perspective, our main priorities are very careful monitoring and then doing what we can to help decrease that intracranial pressure. So the monitoring includes vital signs, neurochecks, and may even involve monitoring the intracranial pressure itself. And I'll show you a picture of that in just a minute. To try to decrease pressure within the cranium, we can elevate the head of the bed, and usually we remove a pillow as well. And then we want to decrease stimulation. So lower the lights, make sure there's not a lot of noise, turn off the TV, just try to keep that room as dark and quiet as you can while still providing the nursing care necessary. If your patient is sedated or intubated, we'll also consider some passive range of motion exercises just to help maintain the flexibility in those joints for the duration of that sedation. Here's a picture of that intracranial pressure monitoring that I was talking about. There's some sort of attachment on the top of the head where a probe is actually introduced directly into the brain cavity, and then the wires go off to the wall, and we have various ways of monitoring that pressure, whether it's an electronic monitor or an old-fashioned what we call manometer. And in this case, there's even a drainage bag attached to remove any excess fluid. So to wrap things up, we talked about the causes of increased intracranial pressure. We talked about the anatomy and those important components within the cranial space. And then we talked about medical management and nursing management. But remember that ultimately, we're going to look for and try to correct the cause of that pressure.